Hello students, welcome to the new session of the cardiovascular physiology. In this lecture we will see about the cardiac cycle. Now, what is the definition of cardiac cycle? They are the cyclical changes which are taking place in the heart from beat to beat. That means from one heartbeat to next heartbeat. What are the pressure and volume changes that are taking place in the atria? What are the pressure and volume changes that are taking place in the ventricle? All this together is called as the cardiac cycle. How much is the normal duration of the cardiac cycle? So we know that how much is the normal heart rate? If we take the normal heart rate as 72, then the duration of the cardiac cycle will be 60 divided by 72. That means it is equal to 0.8 seconds. How much is the duration of the systole and diastole in that? We can divide it into atrial systole and atrial diastole. We can divide it into ventricular systole and the ventricular diastole. So the atrial systole lasts for about 0.1 second and atrial diastole lasts for about 0.7 seconds. So that comes to together, the atrial events comes to together about 0.8 seconds. Whereas for the ventricular one, the ventricular systole will last for 0.3 seconds and ventricular diastole will last for 0.5 seconds. So that is again equal to 0.8 seconds. Now, what are the events or what are the phases in the cardiac cycle? So we can divide it into atrial events and the ventricular events. So first, the action potential has started in the essay note. It will spread to atria, and because of the spread of the action potential, the atria will contract. So we can call it as the atrial systole. Now, the atrial systole will cause pumping of the blood from the atria into the ventricle. But before the atrial systole has begun, the blood was passively moving from atria into the ventricle since the atrioventricular valve were open. So, atrial systole as such will contribute only about 25% of the end diastolic volume. Rest of the blood has passively already filled the ventricle. So, therefore, atrial systole as such mechanically is not important, but the atrial systole is important in such a way that when the action potential spreads into the atria, then only it can go to the AV node and then the ventricle. After the atrial systole, the atria will go in a state of diastole. That means it will go in a state of relaxation. And at this time, the superior vena cava, inferior vena cava, even the pulmonary veins, they will be filling the atria. Now, coming to the most important, the ventricular events. So after a delay about 0.1 second, the action potential now spread into the bundle of his and then rapidly it will spread to both the ventricles. And now because of the spread of this action potential, both the ventricles will start contracting. So we will start with the first phase, that is ventricular systole. So ventricular systole is again subdivided into number of phases. So as soon as the ventricle will start contracting, now what was the picture before the ventricle has started contracting? The semilunar walls, the aortic walls and the pulmonary walls, they are in a closed state. Whereas the AV walls, atrioventricular walls, that is the mitral and the tricuspid wall, they are in an open state. Now the ventricle has started contracting. Because of the contraction of the ventricle, what will happen now? The pressure inside the ventricle will go on increasing. So once the pressure will go on increasing, the blood will try to regurgitate back, or the blood will try to flow back into the atria because the atrioventricular walls are open. But this regurgitation of some blood into the atria will cause closure of the AV walls. So what has happened now? The AV walls, they have closed now once the ventricle has started contracting. And now what is the situation of the ventricle now? The AV walls, they have closed now. Semilunar walls, they are already closed now. And the ventricle is contracting as a closed cavity. So if the ventricle is contracting as a closed cavity, there will be no change in the volume. The end diastolic volume, which is about 120 ml, it will remain constant, but the pressure, since the ventricle is contracting as a closed cavity, the pressure will rapidly increase. This phase where the ventricle is contracting as a closed cavity, the first phase of the ventricular systole is called as isovolumetric contraction phase. What do you mean by iso? Same. Volume will remain same. So isovolumetric contraction phase. What will happen in this phase? The volume will remain constant, that is about the end diastolic volume, but the pressure will tremendously increase. And now, what is the aim of this phase? The pressure should increase so much that the pressure should become more than that of aorta or in the pulmonary trunk. So if you take an example for the left ventricle, the semilunar walls are closed because the pressure inside the aorta is more than that of the ventricle. So if the ventricular pressure becomes more than that of the aorta, it is going to cause the opening of the semilunar walls now, and blood will flow from the ventricle into the aorta. So what is the aim of the isovolumetric phase? The aim of the isovolumetric phase is to increase the pressure in the ventricle more than that of the either aorta or the pulmonary trunk, so that the semilunar walls can open. So if I take about the pressure change in the left ventricle, how much the pressure would increase? The pressure would increase in this phase, the pressure would increase from 0 mm of Hg to more than 80 mm of Hg. So it will go beyond 80. So once it reaches just beyond 80 now, the semilunar walls will open. Now the next phase will begin. So what will happen in the next phase? Rapidly the blood from the ventricle will go into the aorta. This is called as ejection phase. So initially the pressure inside the ventricle will be too high. The ventricle is in the state of contraction. So rapidly the blood will be ejected out. So this phase is again subdivided into rapid ejection phase, and then later on it is divided into slow ejection phase. What will happen in the rapid ejection phase? The ventricular pressure will go on increasing. It can go up till 120 mm of Hg or 130 mm of Hg. And then afterwards, when the blood has been ejected out into the aorta, now the aortic pressure will go on increasing, whereas the ventricular pressure will go on depleting. So this phase, the latter half, is called as the slow ejection phase. So next phase is the ejection phase of the systole. So here the systole will end now, ventricular systole. What are the pressure and volume changes in this phase now? The volume of the ventricle, let's say the left ventricle, the stroke volume has been ejected out. So out of about 120 ml, that is the 70 ml has been ejected out. That is the stroke volume. 50 ml will remain in the heart of the ventricle. So the stroke volume that will be ejected out. Then what is the pressure change? Pressure from here, it can increase to 120 and again it will come back to 80, or it will start depleting. But what will happen to the pressure inside the aorta now? The pressure inside the aorta, it can go from 80. Normally the pressure inside the aorta is 120 by 80. So 80 is the diastolic blood pressure, but this is the time of the systole. So the pressure will again, it can increase to 120 mm of Hg. It will increase to because of the filling of the blood now. So with this, the ventricular systole phase will end. But now the ventricular diastole will start. You have to remember that the aorta is an elastic artery. So what is the function of the elastic artery? Whenever the blood is put in that, it is stretched, and into response to stretch, now it will contract again. So now what will happen? The aorta will start contracting. Because of the contraction of the aorta, the pressure inside the aorta, it will go on increasing. And now when the pressure inside the aorta is more, pressure inside the ventricle is less now, the backward flow will start. Because of this backward flow, now there is sudden closure of the semilunar walls. So this phase, initial phase of the diastole, when there is a backward flow from the aorta into the ventricle, this is called as protodiastole. So what happens in the protodiastole? Slight regurgitation of the blood from the aorta into the ventricle, and because of that, there is a closure of at the end of this phase, there is a closure of the semilunar walls. And now again the ventricle, the mitral and the tricuspid wall, they are already closed, and even the semilunar walls will close now, and now the ventricle will relax as a closed cavity. So this phase is called as isovolumetric relaxation phase. But what has happened in this phase now? Ventricle is relaxing. So what will happen to the pressure? The pressure will suddenly fall. Since both the walls are closed now, there is no change in the volume. So the volume will remain same, 50 ml, whereas the pressure will rapidly decrease. Even it can come to about 0 mm of Hg. So what will be the aim of this phase? The aim of this phase will be to decrease the pressure to such a level that the mitral wall and the tricuspid wall, they open. Because when the pressure inside the atria will be more than that of the pressure inside the ventricle, then only the mitral and tricuspid valve will open. So what happens at the end of the isovolumetric contraction phase? The opening of mitral and tricuspid valve or AV valves. And now, up till this time, the mitral and tricuspid valve were in the closed state. So lot of blood has been accumulated in the atria from the superior vena cava, inferior vena cava, as well as from the pulmonary veins. So as soon as the mitral and tricuspid valve they open, rapidly blood will rush from the atria into the ventricle. This phase is called as rapid filling phase. So what happens in rapid filling phase? The ventricle is filled with the blood from the atria and the volume of the ventricular blood will suddenly increase. Rapid filling phase will be followed by a slow filling phase, or which is called as the period of diastasis. That means where passively the blood is coming from superior vena cava, inferior vena cava, it's going to the atria, and from atria it is going to the ventricle. So this is the passive flow of the blood that will occur. So this is called as period of diastasis. And up till this time now, the next action potential will start, and it will spread over the atria, and it will start the atrial contraction. So, but at that time the ventricle will be in a state of diastole. So, this last rapid filling phase or the atrial systole, which is going to cause more filling, about 25% of the filling of the ventricle, is called as last rapid filling phase, which coincides with the atrial systole. Whenever it comes to about the pressure changes in the right ventricle, the pressure changes in the right ventricle will be less as compared to that of the left ventricle. But it will be the similar. Volume changes will be the similar to that of the right ventricle and the left ventricle. So these are the phases of the cardiac cycle. Now coming to the heart sounds. Normally we know about the two heart sounds. We will call it as S1 and S2. S1 is also called as lub, and this is the dub sound. What is the cause of the production of the heart sound? The heart sounds are produced because of the turbulence created. When the turbulence created, sudden closure of the valves. Now, before that is when the isovolumetric contraction phase. Before the isovolumetric contraction phase, what has happened? The ventricle was in a phase, was started contracting. The pressure will increase, and there will be some regurgitation of the blood from the ventricle into the atria. But this regurgitation will be immediately blocked by closure of the AV valves. This sudden closure of the AV valves will cause regurgitation or turbulence that is created. Turbulence is created into the ventricle, and this, because of this sudden closure of the AV valves, will produce which sound? S1 sound or L, that is lub sound. What is the peculiarity of this sound? This is low frequency soft sound. Next, we have got the dub sound or the S2 sound. What is the cause of this sound? Sudden closure of the seminal valves. Now when this occurs, this will occur just before the isovolumetric relaxation phase. So a multiple choice question can be asked that S2 sound or the second heart sound is produced at the beginning of which phase or at the end of which phase. So you should be able to write that it is produced at the end of the protodiastole, or it is produced at the beginning of the isovolumetric relaxation phase. The basic cause of the closure of the seminal valves is that the elastic aorta, because of the elastic aorta, the pressure in the elastic aorta that is increased, and because of that there is a backward flow. Same principle remains same with the pulmonary trunk. But as I have told you, the pressure changes in the ventricle or the pressure changes in the left ventricle and the aorta are much more higher than that of the pulmonary trunk. So the backward pressure or the pressure that is generated in the pulmonary trunk will also be less compared to that of the ventricle. If the backward pressure is less, or the closure of the valves will be slowly a little delayed, pulmonary valves, compared to that of the aortic valves. Aortic valves will close fast compared to that of the pulmonary valves, because the pressure in the aorta is more than that of the pulmonary trunk. This slight delay in the closure of the pulmonary valve will produce what is called as splitting of the second heart sound. So this is called as physiological splitting of the second heart sound. This is pathologically also important. It can be aggravated in some condition. It becomes reverse in some conditions. Now, Sometimes we also hear about the other sounds which are called as S3 and S4 sounds. Again, these are normally not audible, but if the viscosity of the blood is less, or in case of anemia, these sounds can become prominent. This is again because of the turbulence that is created. S3 sound is because of the rapid inflow phase or rapid filling phase. As soon as the AV valves they open, lot of blood has been accumulated in the atria, and as soon as the AV valves open, the blood will rush into the ventricle. And again, this can create a turbulence, and that will produce the S3 sound. What is the cause of S4 sound? It is the atrial systole. If atrial systole, more amount of blood enters into the ventricle, and there if the turbulence is generated to produce a sound, then that sound will be called as S4 sound. So what is the cause of S4 sound? It is atrial systole. What is or last rapid filling phase. And what is the cause of S3 sound? The rapid filling phase. In short, we will see about the murmurs and thrills. Apart from this heart sound, if any other abnormal sounds they are heard, they are called as murmurs. And these murmurs are useful to diagnose some of the conditions. So what is the definition of murmur? The abnormal heart sound. Murmurs and thrill. What is thrill? A palpable murmur is called as thrill. Now again, what causes the generation of the abnormal sound? The turbulence that is created. The turbulence that is created in some abnormal situation, such as stenosis or regurgitation of the wall. Now first try to understand the concept of stenosis and regurgitation. What is stenosis? Stenosis is a condition in which the wall does not open completely when it should open. To give an example, a mitral valve, when it should open at the time of the diastole, and the blood from the atria should flow into the ventricle. If it is not able to open completely, what will happen? The blood in the atria will have more difficulty to pass, and the atrial systole, especially at the time of atrial systole or the rapid filling phase, the blood will try to force down into the ventricle. So this can create a turbulence. A classical example I can give is of the aortic stenosis. Now the pulmonary aortic valves should open completely at the time of the systole, ventricular systole. But if they are not able to open completely, then the condition is called as aortic stenosis. So what will happen? The ventricle will start contract forcefully, and blood will rush out through a narrow opening in the aorta, which can cause a sudden blowing murmur, harsh murmur. So this is because of that, right? But what is regurgitation? Regurgitation we can define as when the wall should close completely, it is not able to close. To give an example, the mitral wall should close during ventricular systole. If it does not close, what will happen? Blood, when it is going into the aorta, at the same time it will also go into the left atrium. So again, it will create a sound. That is because of the regurgitation. So what causes the generation of the murmurs is either the stenosis or the regurgitation. The murmurs can be even generated because of the patent ductus arteriosus, or even if the foramen ovale that is patent. So in that case also the blood flow, abnormal blood flow, that can also generate the murmur. Basically murmur is because of the turbulent sound that is being produced. In short, we will see about the types of murmur and what are some few conditions in which they are seen. Systolic murmur. Systolic murmur means what? A murmur which is heard in the systole. The common cause is that now during the systole, the ventricle is contracting and the blood should go into the aorta. So if there is an aortic stenosis, it will create a systolic murmur. Or if there is a mitral regurgitation or tricuspid regurgitation, it will create a systolic murmur. So the systolic murmur can be there either because of aortic stenosis or mitral regurgitation. Diastolic murmur, a murmur during diastole. What causes the diastolic murmur? Suppose if the mitral valves, they are not open completely and the blood from the atria is not flowing completely into the ventricle. It is flowing through the narrow opening. So the mitral stenosis can produce diastolic murmur. At the same time, if the semilunar walls of the aortic walls, they don't close completely during the diastole, And now what will happen because of that? There is some regurgitation of the blood from the aorta into the ventricle. This can even create sound. So what are the causes of diastolic murmur? Aortic regurgitation or mitral stenosis. A continuous machinery murmur can be heard in the patent ductus arteriosus, where the continuously blood is flowing from aorta into the pulmonary trunk, right? So that can even cause the continuous machinery murmur. Now we will see about the arterial pulse. What is arterial pulse? First, what is the cause of generation of the pulse? Whenever the ventricle contracts, it will put some amount of the blood. The stroke volume is put inside the aorta. The aorta is already filled with the blood. So what the aorta will do? A column of the blood which was already filled in the aorta, that will be shifted forward. That column will shift the fluid, again blood forward. So because of this shifting of the column, the vessel will expand. The wave will be generated, and the expansion of this wave, we can feel it in the form of the pulse. So what is the pulse? It is because of the wave of expansion which is generated because of the filling of the vessels in already filled vessels. Right? So this is because of the systole and again the filling of the vessels. Now if I record the pulse, that is its uplift and the downward flow, that is downlift, then I can have this type of graph. This pulse is recorded. What you can see is that it has got the two limbs. We can call it as the anacrotic or ascending limbs, and we call it as the catacrotic or descending limbs. So there are the two limbs, and ascending limbs and the descending limbs. There are certain waves which are seen here. This is called as percussion wave. Then this is called as tidal wave. This is called as the diacrotic wave, and this is the diacrotic notch. So what are the causes of these different waves? Percussion wave is because of the rapid ejection phase. Percussion wave is because of the rapid ejection. Rapidly the blood is ejected out into the aorta, and because of that we get the percussion wave. Then we have got is the tidal wave. This tidal is because of the slow ejection phase. And then we have got is the diacrotic notch. So after the slow ejection phase, what will happen? Some backward flow and sudden closure of the aortic walls. So the sudden closure of the aortic walls will cause the diacrotic notch. And then afterwards, once the aortic walls they have been closed now, the blood will slowly move towards the periphery. So this movement of the blood, ultimately it is going to cause this diacrotic wave. So these are the various types of pulse, and we can record the pulse in some even abnormal conditions. So if I record the pulse, I can diagnose some of the abnormal conditions related to that. As you can see in this slide now, a picture that is called as water hammer pulse, which will rapidly rise and rapidly fall. This can be seen in aortic regurgitation, because in aortic regurgitation the end diastolic volume will increase because the blood is regurgitating. At the same time the stroke volume is also increased. So if the stroke volume has increased, there will be rapid ascent, that is the ascending limb. But since the blood is regurgitating back, the resistance as such will be decreased, and there will be sudden fall in the pressure. So you will get a rapid increase and the rapid fall. It is called as water hammer pulse. Then we have got in aortic stenosis, we get the anacrotic pulse. What will happen in aortic stenosis? Very less amount of the blood that will be ejected out into the aorta. So overall the amplitude of the this pulse that will decrease, and the smaller waves that will be recorded. So this is called as the anacrotic pulse. Then we have got is the pulsus alternans, that is seen in myocardial infarction. What happens? A strong pulse then followed by a weak pulse. This is called as pulsus alternans. What is the cause of this pulse? Myocardial infarction, the heart has become weak. So the one contraction might be strong enough, but the next contraction will not be that much strong. Again the heart recovers, and again it causes more forceful contraction. So one strong contraction then followed by a feeble contraction. So this causes the pulsus alternans. Bispherian pulse is combined of aortic stenosis and regurgitation. So we'll get a combination of the tall pulse as well as the short pulse. That's pulsus paradoxicus. Normally what should happen? During inspiration, the heart rate should increase. But if the pulse disappears at the end of deep inspiration, this is called as pulsus paradoxicus. The normal sinus arrhythmia, that will disappear. So this can be seen in pericardial effusion. So pulsus paradoxicus can be diagnosis of the pericardial effusion. So with this we come to the end of this lecture. Thank you.